Good afternoon, everybody. We all know that monsoon season, whenever it comes, we are all pleasant. We have got a pleasant atmosphere to enjoy following the summer season. But whenever there is a monsoon season, we have to face some of the common diseases which are quite commonly seen during monsoon season. And what are these diseases which are quite prevalent or quite common during monsoon season is that one of the very common disease is a dengue fever. And presently we are all aware that all over the Nagpur, Vidarbha and almost all over the India, we find that the dengue cases, the outbreak of this particular disease is occurring at a very high speed. So let us come to the what is meant by dengue fever. First of all, dengue fever means whenever the patient develops a fever, febrile illness, lasting for a period of almost 2 to 7 days, and this fever is usually biphasic. They have got sometimes chills to begin with. There may be a history of exposure to mosquito bites or may not be, more commonly seen in children, and they have got along with that headache, pain behind the eyes, that is retroorbital pain, and pain in the chest, pain in the abdomen, pain in the limbs, pain in the joints. So all painful conditions, and therefore this particular disease is also known as a bone break fever or also known as back break fever. So these are the various names given to this particular disease. This is called as a dengue fever. Now dengue fever is not so simple as I have explained. It also has got the complications along with it, and they may be in the form of what is called as a dengue hemorrhagic fever. Dengue hemorrhagic fever is the one when patient has got clinical symptoms and signs of bleeding and also has got a low platelet count below 1 lakh per cubic millimeter. This particular entity is called as dengue hemorrhagic fever. Now dengue hemorrhagic fever also is associated with the capillary permeability being lost, and because of the increase in the capillary permeability, there is a loss of fluid from the intravascular compartment to the extravascular compartment along with the plasma proteins. Therefore, these patients do have got periorbital edema, edema over the feet, edema over the hands, sometimes over the abdomen as well. So this particular manifestation is one of the peculiar things which you see in a patient of dengue hemorrhagic fever. Now initially one may not be able to notice whether patient has got plain simple dengue fever or dengue hemorrhagic fever. So you have got a very simple test, what is called as a tourniquet test. The tourniquet test comprises of applying a BP cup to the arm and raising the blood pressure between systolic and diastolic, keeping it for a period of 5 minutes and watching for evidences of PTG over 1 square inch area. If you have got more than 10 such PTG, that suggests that the patient has got the capillary fragility or a tourniquet test positive, and that is again suggestive of the patient having a dengue hemorrhagic fever. Now this dengue hemorrhagic fever may not stop at this moment. This patient may have got the further problem that the fluid loss is so torrential, so severe that the patient looks very much edematous. He has got generalized anasarca, and at the same time he has got the tachycardia because the intravascular compartment goes down. The patient's blood pressure drops down. The pulse pressure, that is difference between systolic and diastolic pressure, decreases to less than 20 millimeter of mercury. Now this patient somehow or the other is able to maintain his vital signs. He may or may not have cold extremities, and he has got blotching, erythema, rashes all over the body. Now this patient is called as a patient of dengue shock syndrome, which may be in a compensated phase. But if such patients or children, they are not being taken care of properly, they are not given fluid therapy properly, then these patients do go for a next stage, that is called as dengue shock syndrome with a irreversible shock, or what is called as a severe dengue syndrome. Now this severe dengue or a dengue shock syndrome furthermore may develop organ damage. Organs which are mainly affected, they are the lungs, the liver, the kidney, adrenals, brain, heart, and all these organs, when they are affected, these patients do develop various clinical signs. So when the organ pathology occurs in these patients, this particular dengue shock syndrome is called as a severe dengue patient, a severe dengue patients. Now this is all about what are the various parameters to diagnose various subtypes of dengue fever and its subordinates or its severe entities. Now coming to the how the patient develops fever. Initially there is a mosquito bite. Whenever the mosquito bite occurs, these viruses, they are poured into the skin from the salivary gland of the Aedes aegypti mosquito, which is the vector of this particular disease. This Aedes aegypti mosquito is a very daredevil mosquito. It bites during day hours. It doesn't bite in the night hours. It bites for more than one person. So in a family member, at a time or at a single sitting, it can infect more than one person in a family member, and therefore there are cropping up of the cases in a particular family. So this is about the Aedes aegypti. The another brother of this Aedes is a Aedes albopictus, another virus, another mosquito which is also a vector, and that also carries this particular virus, and it acts as a vector to transmit the infection from one infected person to the another infected person, particularly the children. Now coming to the epidemiology, I told about the vectors. What about the environment? You will find that this disease is more common during monsoon. That means after the end of June and onset of July to the end of December. This is the particular period where you have got many more persons, including children, being infected and suffer from this particular disease. So the monsoon phase, the right from say July to December end, is a period when you have got maximum number of cases of dengue fever. Now next comes to the host. What is the peculiarity of the host? The common host who is being the victim of this disease are the children. The children below 15 years of age, they constitute more than 90% of the total cases of dengue fever patients. So that is the magnitude of the disease being affecting the children. So children are naturally the victims, and they have got lot of morbidity and sometimes even mortality if the patient develops a severe disease. Now once the virus enters the skin, it multiplies in the Langerhans cells of the skin. There the viruses multiplies, and from there then they escape into the blood circulation. Now once they escape into the blood circulation, by virtue of the receptor, they infect the macrophages, they infect the monocytes, and by entry into these particular cells, they inhibit the innate immunity. Whatever the innate immunity is present in the person, that is being inactivated or it is being diminished by these viruses, and therefore there is a excess of or significant proliferation of these viruses in the monocyte. Now along with that, the viruses also attaches to the antibodies created by the previous infection. If a child has developed the dengue virus in the past and he has got two types of antibodies, one is the neutralizing antibodies which are specific to the particular virus serotype, but another type of antibodies, they are the infection enhancing antibodies. They are not protective, or rather they enhances the infection by the other serotypes. Now what happens when these viruses enter the circulation, they combine with these particular antibodies, these are nothing but the infection enhancing antibodies. This complex ultimately again enter the monocytes, again stimulate the monocyte to create the cytokines, and multiple cytokines are being released. Now, the cytokines released from the macrophages and the monocyte also get fixed to the T lymphocyte, which has got a memory cells. Now, these memory cells, because of the prior infection, they also get activated and they also release many cytokines. Now, these cytokines, they have got two types of action on the body. One is that it acts on the complements, the various complements like C3, C4, C1q, C5 and C1, C8, all these complements, they are activated and then again they are being utilized and therefore they decrease. At the same time, there is a significant increase in certain other cytokines, what is called as the tumor necrosis factor receptor, the interferon gamma and other types of cytokines including the interferon 2. So, all these types of cytokines, they ultimately attack the blood vessels. The blood vessels, the permeability is decreased and therefore the permeability of the endothelial cells, they get increased and therefore there is a seepage of fluid outside the intravascular compartment and the patient go on losing the fluid and therefore he becomes edematous, he becomes hypotensive. Now, hypotension on one side, cytokines on another side and the loss of blood circulation to the peripheral tissues giving rise to hypoxia, all these three things culminate together to form a DIC. Now, once DIC occurs, the coagulation factor, the clotting factor, they are all being consumed by the particular process and they develop what is called as a DIC. This DIC along with shock, both these things, they are responsible for death of a child if it is being not timely being taken care of and being treated. So, this is all about the mechanism, the pathogenesis, how does it give rise to various symptoms and the complications. Now, coming to the management part, how we take care of these patients. Now, before you go for any management, you have to classify these particular patients into various categories so that our management gets properly streamlined. Okay. So, for that purpose, first and the foremost, you have to categorize them and the WHO has given various classifications. One is called as first and the foremost is called as a undifferentiated fever, viral fever, where patient has got symptoms, any viral symptoms, viral fever symptoms like fever, malaise, the loss of appetite, body ache, and the diagnosis is yet not being confirmed and patient do not have petechiae, patient do not have even the edema. This particular stage of the disease is called as a viral undifferentiated dengue fever. The next stage is a symptomatic patient. The symptomatic patients, they could be just like the dengue fever, the classical symptoms of fever along with various pains, what I have already described, right from headache, retroorbital pain, the chest pain, the abdominal pain, the myalgia, the arthralgias, all these, any of these two, and they may have the presentation of what is called as a dengue fever. The third is the patient with a warning signs. Now, warning signs, dengue fever with warning signs means the patient has got a severe pain in abdomen. He is all the while restless because of the pain in the abdomen, vomits sometimes, the vomiting is recurrent and he is not well and he may have got a rashes. The rashes initially is erythematous, it blanches on pressure and as the disease process progresses, the febrile illness it disappears over a period of say 2 to 7 days and then it is replaced by a phase what is called as a critical phase. During critical phase, what is called as a severe dengue fever as described by WHO or classified by WHO as per 2009 classification, these patients do have got the signs of shock. That means their extremities may be cold, they are restless, they may be drowsy, sometimes they develop convulsions, they are not able to maintain posture, urine output decreases, they are edematous, they have got circumoral cyanosis. So all these symptoms, when they are there, then you call that this patient has got a severe dengue. Now the management part, as far as is concerned, the management combines with the first and the second type. That means undifferentiated fever and dengue fever patients, they need a home care in the form of the supportive care. Supportive care comprises of the temperature correction. That means you have to give tepid sponging first of all, that is the mainstay of treatment. At any time you can lower down the body temperature of the patient by cooling the extremities as well as whole body by a lukewarm water. The cold water or chilled water should not be used because it induces further chilling, further rigors, and therefore again increases the body temperature. So what is required is to cool down the temperature by just a lukewarm water. That is number one. Number two is a paracetamol. Paracetamol is to be given in the dosage of 10 to 15 milligram per kg body weight, minimum 3 times a day to as much as say 5 to 6 times a day. But care should be taken that patient do not vomit the dose. If he vomits within half an hour, the dose has to be given, repeat the dose again. The third precaution is that other antipyretics like NSAIDs has to be avoided. Otherwise, these patients can have a bad effect on the platelets and the platelet function will decrease and the patient may bleed unnecessarily. So that precaution has to be taken, that the patient has to be given either sponging or with a paracetamol. These are the two things which is to be given, plus fluid replacement. The child is febrile, he is losing the fluid from the body, from the skin, and therefore he needs to be given a plenty of fluids. The normal fluid requirement on an average child is around 100 cc per kg body weight. That has to be given frequently. If he vomits, the small sips is to be started initially and then gradually stepped up. So this is how the fluid therapy is given. The type of fluid to be given, homemade fluid, like say for example you can give lemon juice, you can give coconut water, you can give the normal. Suppose a small child, infant is there, then you have to give the milk only, and even the buttermilk can be given to a older child. Along with that, you can give the ORS, oral rehydration solution, is the mainstay in management of these particular children. And you have to keep a watch that the child is passing urine frequently. Minimal amount of or frequency of urine volume to be passed by a child of this category 1 and 2 is at least 4 to 6 times a day. If he is not passing that much amount of urine, then these patients needs to be again re-evaluated, and if you find that the patient is deteriorating, then the patient needs to be hospitalized. Now stage 3, patient who has got a dengue hemorrhagic fever. These are the patients who has got a warning signs, who has got a tourniquet test positive, who sometimes can have epistaxis, who can have the GI bleed and sometimes hematuria and other bleeds. Now these are the patients who need to be monitored very significantly, almost say every half to 2 hourly. One has to monitor their vital parameters like heart rate, temperature, respiration, the urine output. The weight also has to be taken care of every 6 hourly or every 12 hourly depending upon the severity of the disease, and to watch for any bleeding diathesis, and then the fluid replacement has to be given. If child is not able to take the fluid orally, either because of anorexia or because of recurrent vomiting, then one has to start with the intravenous fluid therapy. Now the intravenous fluid therapy to be given in a child who has got a dengue hemorrhagic fever but without signs of shock is that you start with the fluid, IV fluid. The fluid of choice is either normal saline or a ringer lactate, to be started at the dose of 6 to 7 cc per kg body weight. Now this is to be given, this amount is to be given over a period of half to 1 hour. Then again re-evaluate after 1 hour, watch for the temperature, watch for the heart rate, watch for the blood pressure, the pulse pressure which was narrow, whether there is a increase in the pulse pressure or not, that has to be found out, and then accordingly you have to find out whether the child is either responding to your treatment, then call it as a yes. If not responding, then call it as no. If he is responding, then the amount of fluid to be given has to be reduced. From 7 cc per kg, you have to reduce it to 5 cc per kg for another 2 to 4 hours, and then again watch for the urine output and the vital parameters. If child is again responding, then the fluid to be given has to be reduced down to 3 cc per kg per hour. These are all per hour, and has to be given for the next 24 to 48 hours. If child is all right, child can be discharged at the end of the 48 hours. Now, if the child is not responding, there is to the initial 7 cc per kg bolus fluid therapy, then you have to increase the fluid volume to 10 cc per kg or 15 cc per kg depending upon the response, and then the has to be managed accordingly. If child has got, during this particular management process, you also have to monitor the hemoglobin and the paxil volume or hematocrit. If the hemoglobin or the paxil volume is rising, it indicates the child has got hemoconcentration and there is a significant loss of fluid from the intravascular compartment. In this case, your patient is not significantly improving, and therefore you have to increase the fluid requirement, and that has to be given to the child. So, that is all about the management of a child. But suppose, for example, the hematocrit is dropping and child is not responding, then in that case, if the hematocrit is dropping and the child's vital parameters are stable, BP is getting normal, that means that the child is responding, so you need not bother. But if the vital parameters are decreasing, that means tachycardia is still there, the pulse pressure has narrowed down, urine output is not good, and the hemoglobin is also dropping down, that will indicate that the patient is having some concealed hemorrhage significant enough, and in that case you have to give a plain fresh blood transfusion so that his vital parameters has to be stabilized and the bleeding tendency can be controlled. Now, this is about the dengue hemorrhagic fever. Coming to the dengue shock syndrome, the patient who has come with a cold clammy extremities, the pulse pressure is less than 20 and he is restless, he is irritable, he is edematous. In these cases, you have to start with the fluid initially again 10 to 15 cc per kg body weight and see the response within 1 hour, and if you find that the patient is responding, then go on decreasing the fluid therapy from 10 to 7, 7 to 5, 5 to 3 per cc per kg body weight. But if there is no response, then you have to increase the fluid therapy to 20 cc per kg for another 1 hour and again review the child both clinically as well as by laboratory parameters, and if you find that the patient is not responding, then you have to go for the either check for hematocrit. If hematocrit is dropping down and patient is not responding, then in that case he is again bleeding, and then you have to go for a transfusion or a paxil transfusion. Now, if the patient, third category, patient has come in a pulseless patient, that means his pulses are not palpable, BP is not recordable, child has got cyanosis, child is stuporose. In that case, what to do? In these patients, you have to start with, right in the beginning, 20 cc per kg of normal saline or ringer lactate to be given within a period of 15 to 30 minutes only. Need not wait for 1 hour. And again review the patient after 15 minutes. If his pulses are palpable, well and good. If not, again repeat the dose. So 20 cc per kg again to be repeated, and even after this 20 plus 20 around 40 cc per kg, you find no significant change, you have to find out what is the cause of it, whether the hematocrit is better or higher side or whether it is on a lower side. If hematocrit is on a higher side, it indicates that the child is still losing fluid from the intravascular to the extravascular compartment. You have to continue the fluid therapy and then again review the child. But if the hemoglobin is dropping down, again you have to give paxil transfusion or a fresh blood transfusion. Now, in spite of all these things, if the patient is not responding, giving blood transfusion, everything, then comes the role of sympathomimetic drugs. So, dopamine or dobutamine can be given to these patients in a dose of 5 to 10 microgram per kg per minute and monitor the child again. Now, you have given the fluid therapy. The complicated patients of dengue shock syndrome is the fourth category. Now, because of the fluid therapy, the patient is now dyspneic he is edematous, he is bloated, he is having a generalized anasarca. Now what to do? His oxygen saturation is dropping down. You have to support his respiratory system. You have to give him oxygen, give him a diuretic, that is Lasix has to be given in the dose, bolus dose of 0.5 mg per kg, followed by say 1 to 4 mg per kg slow perfusion or slow infusion to be given over a period of say 4 to 6 hours. Again watch for the child's urine output and other things, and then manage accordingly. But in spite of that, if patient's oxygen saturation is not maintained, then comes the role of central venous pressure monitoring to know whether patient really has got a respiratory distress because of fluid overload, or whether he has got a ARDS, acute respiratory distress syndrome. If he has got ARDS, then he needs a ventilator therapy. And if CVP is raised, then you have to again go for more doses of say diuretics. But if diuretic is not still working well, then in that case these are the patients where last but not the least you have to go for a peritoneal dialysis. So this is how in nutshell how to manage a patient of dengue fever and its variants and complications. Now how to prevent this disease? The prevention is more important than the cure of the disease, and prevention can be taken care of by only two methods. One is vector control and second is human control. Now what is vector control? Vector control means you have to use the say insecticides, or you have to say dispose of the water collecting bodies in the form of say coconut shells or the household water collections for drinking water or something. So that has to be replaced every say 24 to 48 hours, so that the larvae are not breeding over there and then mosquitoes are not coming up. So that is one aspect of prevention. Second thing is personal, the human being itself. So you can use the say mosquito nets and mosquito repellents. The problem with the mosquito nets is that you can't use during day hours, and these mosquitoes are the one who bites during day hours. So the role of mosquito net is relatively less in this particular disease. But you can at least go for a fogging during the day hours, a community fogging by the insecticides that can be done, so that the mosquitoes can be taken care of. Last but not the least is that you can use the vaccine which is now coming up. It has not been very successful, but the one particular company has come up with a vaccine what is called as a Dengue the vaccine for dengue fever. It contains all the 4 serotypes. It is a live attenuated vaccine, and with the help of the yellow fever as a vector for this particular vaccine, they have prepared it, but it is still in experimental phase. It is not available on for a community basis, and therefore one has to be quite careful about how best to prevent this particular disease. So the last but not the least sentence which I will say, that so long as there is a water on the earth, the vectors will be there, and vector borne diseases will also be there. So therefore one has to take care of the unnecessary water collections and bodies which are there, particularly household bodies, water collecting bodies, so that the breeding of the mosquito can be curtailed down and this particular disease can be taken care of. Last but not the least is the vaccine has to be given due importance, so that early implementation of vaccination can give rise to a prevention from this particular disease. So the tug of war between man and mosquito, that is going to continue till the vaccine is at our hand and we take care of the disease and try to eradicate the disease. One must remember that these viruses, they come from one person to the another. So there is a reservoir only human being. So if the humans are being taken care of properly and segregated properly, then the control of the disease can be achieved. So thank you very much for